Let's see how many times I can not drop the F-bomb.
Dude, I won this battle, so...
Alright. Good afternoon. I'm Christian, and Chris will be talking later. We're actually in the group that's discussing the fact that we're actually against the use of fluid therapy. So the first thing I'd like to talk about is our hypothesis. So our hypothesis will be here, as you can see, that fluid therapy is overestimated in the majority of cases and does more harm than good in trauma patients. So that's our hypothesis. Now I'd like to briefly discuss our objectives for this assignment. For this debate, we're assigned to be against fluid therapy. Thus, we chose to focus on IV fluid therapy in relation to trauma patients, emphasising on burns and hemorrhage. Aggressive IV fluid therapy in these patients will lead to clotting disorders and compartment syndrome. This will be the main focus of our presentation. To begin with, we will cover the basics of isotonic crystalloids, the different fluid compartments, and discuss the relevant drug therapy protocols used in the Queensland Ambulance Service. Furthermore, we'd also like to discuss the history of IV fluid research and how this has led to a tradition of overestimating the amount of fluid administered.
Normal saline, normal chloride, is an acetonic solution and is fundamentally made up of electrolytes. Currently, the QAS is using saline 0.9%. As this substance does not stay in the intravascular compartment for long and is expelled efficiently, it is rendered useless for long-term blood pressure maintenance. The pH of saline is between 5 and 6, and because of the body's buffering system, it becomes a pH of 7 when it enters the system. An acetonic solution has no net movement and no osmolarity. Anywhere between a quarter and a third of saline remains intravascularly, and the rest is dispersed and excreted by means of the body's normal mechanisms. There are 3 compartments that IV therapy affects. Those are intracellular, extracellular, and intravascular. As saline is 0.9%, and moves no fluids, it's great for fluid replacement. However, in traumatic incidences, more effective and appropriate fluids could be administered.
Alright, for this section I'd like to talk about the Queensland Ambulance drug therapy protocols. So there are 5 main reasons why we give fluids and how we actually administer them. So I'd quickly like to talk about that. So the first one is uncontrolled hemorrhage. So with an uncontrolled hemorrhage, we'd like to maintain the blood pressure so we actually maintain a radial pulse. So the next one is a controlled hemorrhage. As you can see, that it's basically just the same, maintain a radial pulse. It's important to know these for head injuries as well. So with head injuries, both open and closed, we'd like to maintain the systolic blood pressure at about 100 to 120 millimetres of mercury, as well as with other fluids that we'd like to just replace the fluids to maintain that intravascular volume. So we'd like the blood pressure to be greater than 90 and a heart rate under 100.
Since IV fluid therapy is one of the most practiced procedures throughout the world and considered to be the standard of treatment for all hypertensive patients, one can only assume that it was based on quality scientific evidence. In fact, it's quite the opposite. IV fluid therapy is based on animal hemorrhage experiments conducted in the 1950s and 60s that were poorly designed, which prevented the true harm of IV fluid therapy from being revealed. The studies prevented the harm of IV fluid therapy from being revealed as they attempted to reproduce the pathophysiological conditions of hemorrhage by withdrawing a standardized amount of blood from the animal's circulation and through a catheter. Improved outcomes were found for all animals that were given fluid therapy. The researchers concluded that animals' treatment with fluid therapy had a better survival rate based on administered fluid increased their circulation volume and blood pressure to re-establish blood flow to critical organs. However, the problem with all these studies is that the hemorrhage had ceased prior to the resuscitation and would not recommence due to its controlled nature. Based on these experiments, there was no possibility increased blood loss could have occurred as the site of blood was controlled by a syringe. These factors prevented the dangers of IV fluid therapy, such as increased blood loss, from being revealed. It wasn't until the late 1980s people increasingly began to question whether fluid replacement might actually be harmful. New animal studies attempted to replicate the same experiments, except this time uncontrolled hemorrhage was achieved externally via rat tail amputation. Based on these studies, it was found bleeding and mortality increased with fluid administration. Therefore, the underlying argument is if these days' original experiments were conducted with today's strict guidelines, the procedure would be labeled dangerous and would not have been implemented as the standard treatment. The procedure has been comprehensively reviewed since the 1960s, and the result of each study revealed the harm caused by IV fluid therapy. The research had concluded fluid replacement was harmful and increased mortality due to increased blood loss through the dilution and clotting factors, reverse vasoconstriction, and mechanical disruption of the blood clots for increasing blood pressure and reducing oxygen delivery, thereby exacerbating shock. A critical argument is that if IV fluid therapy was based on poor quality studies that only considered an increase in blood pressure as a sign of improved outcome, then why is it considered the standard protocol? Far more extensive studies have revealed the true harm of IV fluid therapy can cause, but these have been ignored. This has resulted in the ethical issue where the procedure is freely practiced at the expense of loss of life. This procedure needs to be changed as extensive scientific research has proven the harm of IV fluid therapy. So next up we're going to be talking about dislodging the clot. People's beliefs about the benefits of fluid resuscitation are based on pathophysiological reasoning. Those who support fluid replacement do so on the basis that since shock and degree of shock are directly related to the risk of death, then replacing circulating volume and maintaining blood pressure must reverse it. Therefore, under this ideology, it is intuitive that if someone is losing blood volume, then they should be given fluids immediately. However, there are serious doubts with this belief because it only addresses a person's blood pressure in regards to shock, without acknowledging the consequences of fluid therapy. By administering fluid, it reverses the body's natural responses. The body has a natural response to decrease in blood pressure via vasoconstriction and diverting blood from the peripheries to the major organs. Furthermore, clots are formed at the site of injury to prevent further blood loss. These clots are not overcome due to the decreased flow and pressure. However, when fluid is administered, it reverses these effects by increasing the systolic blood pressure, and this results in the clot being dislodged, causing the rebleeding. The fluid will also increase the circulating volume that has a tendency to increase cardiac output, ultimately increasing blood pressure. These effects will reduce blood viscosity and diluting clotting factors. The aim of administering fluid is to restore organ perfusion and therefore oxygen delivery. But how can this be achieved if crystalloid fluids have no ability to carry oxygen? The argument is that if the patient has an uncontrolled hemorrhage resulting in significantly low blood pressure, that leads to a loss of perfusion to vital organs. Administering fluid will only dilute the blood, and since fluid has no ability to form clots and has no ability to carry oxygen, the vital organs will not receive adequate oxygen to function. The next topic that we're going to be covering is coagulopathy. This follows on from dislodging the clot, which interferes with coagulation due to an increased systemic blood pressure. As will be revealed, coagulopathy also interferes with clot formation and leads to worsening of hemorrhage. Coagulopathy is a pathological condition that arises in approximately 25% of patients admitted to hospital following major trauma. Roughly 75% of these coagulopathic patients are admitted due to blunt trauma. Coagulopathy greatly increases the risk of further hemorrhage and is associated with a 3 to 4 times greater mortality compared to patients without any coagulation dysfunctions. Furthermore, patients that develop coagulopathy have an increased ICU stay and increased risk of organ failure. Coagulopathy is therefore a serious risk that needs to be addressed with appropriate resuscitation control strategies. Coagulopathy is the disruption of the homeostatic coagulation process during severe tissue injury and is defined by a functional reduction in clot strength and prolongation of clotting time. In trauma, this condition manifests as a result of severe tissue injury and hemorrhage and is termed trauma-induced coagulopathy. Traditionally, the lethal triad of factors that arise out of trauma and lead to trauma-induced coagulopathy are acidosis, hypothermia, and hemodilution by intravenous crystalloid. Acidosis and hypothermia are both consequences of traumatic injury, yet in their review, Curry and Davis consider the third factor, hemodilution, as an iatrogenic cause of trauma-induced coagulopathy. The large amount of saline traditionally administered in the pre-hospital environment do not have any coagulation or oxygen carrying capacity, and thus only acts to dilute the reduced blood volume still present in the trauma patient. Apart from the theoretical model, clinical studies such as the one by Miguel and colleagues found a positive correlation of coagulopathy with increasing amounts of fluid administered during the pre-hospital phase of care. More than 40% of patients with over 2,000 milliliters of IV saline were coagulopathic, and over 50% of patients were coagulopathic with over 3,000 mL of saline. This is not just the case for patients overall, but each subcategory of injury severity showed an increased incidence of coagulopathy with volume of fluid given. This concludes that the incidence of coagulopathy is also independent to the severity of injury. IV saline below 2,000 milliliters might play a minor role in resuscitation, as it is not found to interfere with coagulopathy. But for the sake of the patient's survival, more effective resuscitation techniques must be used nonetheless.
Let's look at burns. A burn is defined as damage to the dermis, epidermis, and/or underlying tissue. This can be caused by heat in the form of hot liquids, flame, heated objects, electricity, or chemicals. Let's briefly talk about the pathophysiology of burns. At the site of injury, there is coagulation of tissue and necrosis. Due to this burn stimulus, there is an activation of leukocytes and inflammatory mediators. Saffold states that if greater than 20% of body surface area is burned, dramatic systemic effects are observed. Catecholamines, cortisol, and inflammatory mediators are released, resulting in blood vessels becoming more permeable, leading to edema and fluid shift from the intravascular to the interstitial space. This causes rapid cooling and hypovolemia in these selected patients, leading to high rates of mortality. Next, I'd like to quickly talk about the Burns fluid resuscitation formula used to improve mortality in Burns patients. The QAS advocates that we utilise the Parkland formula for burns greater than 20% of the body. This formula is described as 4 mL per kilo times percentage of body area burned. This formula was conceived in the 1960s and 70s and has been used due to tradition and ease of use. Saffold has also stated that many hospitals give fluids far in excess of 4 mL per kilo and fail to adequately dial back fluids based on renal function and output. Another point is that most health professionals have inadequate exposure to accurately estimate burn size. This could lead to overzealous fluid administration. Saffold and Dulhunty both made reference that infusing too much fluid early on can lead to compartment syndrome. This further results in decreased renal output, subsequent failure due to compression of renal flow. Lastly, compartment syndrome can be best thought of as an increase in pressure in a non-expandable compartment. As the pressure increases due to IV fluid, there's an increase in venous pressure, leading to hypoxia of the tissue. The body responds to this by releasing more histamines that dilate the capillaries to increase blood flow to the area. The histamine causes the capillary membrane to become more permeable, which leads fluid to leak into the surrounding tissue, exacerbating the compartment pressure. There is an eventual complete cessation of flow and necrosis of nerves and muscles in the compartment. This constitutes compartment syndrome. In summary, progress in trauma care requires continuous improvement in everyday patient management based on good, sound clinical trials. IV therapy, one of our most basic trauma care principles, is founded on tradition rather than good clinical research. IV therapy looks at the evidence for use in major trauma situations in light of more promising damaging control techniques. Furthermore, we discussed its lack of therapeutic benefit in burns, compartment syndrome. It dilutes clotting factors, thereby increasing blood loss, and its involvement in coagulopathy. On this evidence, we find that fluid therapy is overestimated and in the majority of cases does more harm than good in trauma patients. We find that fluid therapy is overestimated and in the majority of cases does more harm. Does more ham.
Does more ham.
Does more ham.